Hi everyone, my name is Christian Cicchetti, and I chose to do the Ryan White program for this week's presentation. I'd first like to start off by going over who was Ryan White. Ryan White was born December 6, 1971 in Kokomo, Indiana. He was your average typical kid. However, at the age of 13, Ryan contracted HIV. Ryan lived with a condition called hemophilia, which means that his blood does not have the necessary clotting factors or platelets. Therefore, he must get blood transfusions frequently. It's just part of his necessary medical care. And at one of his transfusions, he did contract HIV. At the time, physicians gave Ryan only 3 to 6 months to live. So even after Ryan's diagnosis and outliving doctors' expectations, Ryan wanted to go back to school. He wanted to attend school. He wanted to see his friends. However, this was not something that was easily accomplished. Him and his mom had to go before courts and fight for the right to go back to school. He was met with a lot of discrimination as well as harassment. And a year later, Ryan was eventually allowed to go back to school, and things didn't get better. Even with education and things like that, there's still a lot of misinformation and stigmatisms around the idea of him having HIV and being in school. Therefore, he transferred school districts and went to a school in Arcadia. And the school board there actually focused on ending the stigmatisms around the disease. They would perform education trainings at the school for the kids, and the kids would take that information home and educate their parents around the treatment and care for HIV. Ryan Sight was important because he became the face for the AIDS epidemic that was growing through the 1980s. Prior to Ryan, much of the focus of the disease was on gay men and injection drug users, which we know these groups typically have low social power. In Ryan's case, a blood transfusion caused kind of a panic across the nation because we were seeing HIV and AIDS in a different population from what they had been seeing before. So his fight against the school and boards like that for his right to partake in education was a big reason of why he became so famous. And after his death in 1990, Congress passed the Ryan White Comprehensive AIDS Resources Emergency Care Act, and at his funeral he had famous figures like Elton John and Michael Jackson at his funeral. Since the bill has been signed in 1990, it has been amended 4 separate times, once in 1996, 2000, 2006, and lastly in 2009 it was signed by President Barack Obama as the Ryan White HIV/AIDS Treatment Extension Act. These amendments are important because it decides where resources are going to be allocated to, different clauses that are added into the bill, what amount of money is going to be spent on certain grants, what qualifies you for certain grants, as well as how much is being allocated to research and what kind of research they're including within the program. Since 2000, the program's been implemented in 1990. It has only expired once in 2013, but is still being federally funded because there is no expiration date on the legislation itself. The program is being administered by the U.S. Department of Health and Human Services, the Health Resources and Service Administration, or HRSA, and the HIV/AIDS Bureau. This is the largest federally funded program that focuses on HIV care. Prior to the passing of the CARE Act in 1990, Congress worked to provide aid to cities and states struggling with rises in HIV cases. They did this by federal grants that were utilized to help pay for medication, other resources, research, and care for mothers and children. This was all accomplished through HRSA. They did this by AIDS service demonstration grants. The grants originally started out with 4 recipients in 1986. These recipients were New York, Los Angeles, Miami, and San Francisco, but by 1990, there were 24 major cities utilizing these grants to care for HIV and AIDS patients. Another program was the AIDS and Drug Assistance Program. However, none of these programs were permanent, and it wasn't until 1997 that Congress even began discussion of a federal program. In 1990, public health officials, physicians, and patients finally gave their testimony about the cost and burden of care for this disease to Congress to demonstrate the need for a federal program to address and intervene with this epidemiological issue. Major role of the program is funding, funding for interventions, medications, as well as research. Funding for Part A of the grant are eligible metropolitan areas, EMAs, or transitional grant areas. For Part B, we have grants for all 50 states as well as the territories. This goes for care, housing, medical resources. And then parts C and D are funding for local community organizations, community health centers, health departments, academic medical centers, and hospitals in all 49 states, as well as the territories. Typically, the grants cover medical, housing, and other resources needed for these low-income affected individuals who do not have the resources to pay for typical care. The program serves over 50% of individuals diagnosed with HIV every year. This has resulted in almost 90% of the individuals being served by the program to be virally suppressed. This allows them to live healthier lives, longer lives, and as well as decrease the transmission of the virus. Just to give you a quick idea of how this works, I'm doing my APE through the Project QC. The project was created around the 1980s when the AIDS pandemic was becoming an issue, and it now has become a lot larger non-for-profit organization. A lot of the services that they provide are HIV and AIDS care services, getting individuals on medications like PrEP and PEP. They also provide mental health and counseling services, LGBTQ plus centered care, and pharmacy services, as well as SCT and hepatitis C testing. All these services are provided at low cost or no cost for the individuals, and much of the funding is through the Ryan White grants that comes from the program. While everyone is at risk for HIV, there are individuals and subgroups that are disproportionately affected by the HIV and AIDS epidemic. We know that those at greatest risk would be gay and bisexual men, African Americans, Latino, and transgendered individuals. Typically, these people have also been marginalized over the past decades, discriminated against. When we look at Ingram's table, we would describe many of these populations as having low power socially. We wouldn't typically describe them as being advantaged subgroups. There could be arguments that they're contenders in some cases, and definitely we see growing in advocacy for these populations and subgroups of people. However, these are the populations that benefit most from the program. There are many barriers of the program, such as lack of insurance, even in states that have free access to this treatment, cost or perception of the cost, substance use, social factors and mental health, homelessness, fear of violence from a partner by disclosing HIV status, as well as fear of family or friends from disclosing that information. Many of these barriers are addressed by the Ryan White program, but education on Medicaid services offered through the state is also a large barrier. So many individuals just don't know the resources that are offered through the state. The overall goal of the program is to end HIV and AIDS within the United States. It corresponds with both programs, the Ending the HIV Epidemic, as well as the National HIV/AIDS Strategic Plan to reduce new HIV cases by 90% by 2030. We essentially have the resources to end the epidemic within the U.S., but there are barriers that still need to be addressed, including linkage to care. Other areas that should be addressed within future outlooks or amendments of the bill are federal non-discrimination laws on the basis of sex and gender, increasing education for healthcare providers regarding HIV and AIDS care, increasing diversity and inclusion training, and providing LGBT affirming care within programs and hospitals. Another outlook to look at is those discrimination and criminalization laws that many of the states have. So when we do evaluate the program itself, we should reevaluate how those laws affect individuals living with HIV and AIDS, and make sure that while they are there to protect other individuals and people and keep everyone healthy, that they are not discriminating on people on the basis of a health condition. Thank you.